Welcome, everyone, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for December 12th, 2023. We have a fun case today. I'm sure we're all going to learn something from it. I'm excited about it. The conference will be recorded. Our CME activity code today is 490067. We do put all these up on our YouTube channel, and if you're not subscribed to the YouTube channel, please do so. And if anybody who aren't on the mailing list for our email alerts, just send us a direct message and we'll be glad to get you on there. We have nothing to disclose, as usual, and patient confidentiality is preserved. In fact, the patient is aware of us presenting this case, so everything is actually straightforward. It's Dr. Whittier's case. Our first-year fellow, Dr. Coleman, is going to read the protocol, so I'll hand it over to you, Michael.
Can everyone hear me okay?
Yep.
Okay. So this is a 59-year-old Black female with a history of gout, hypertension, asthma, and vitiligo, which was diagnosed 2 years ago, who presented with generalized swelling. So she reported a few weeks prior to this, she had swelling in her left foot and big toe, which her podiatrist diagnosed her with gout of the big toe. And she was started on colchicine and prednisone, which she took for 1 week. After this course of medications, she noticed bilateral leg swelling that progressed to her face and hands and throughout her body. And she gained about 15 pounds over 1 month. She was also taking ibuprofen 3 to 4 times a week for the last 3 weeks for the discomfort in her toe. She denied a history of HIV, hepatitis, no recent viral infections. Of note, she saw her PCP about 6 weeks prior to this, who noticed a 20-pound weight gain over 3 months' time. At that visit, her creatinine was normal at 0.8, and her serum albumin was 1.1, but all that was discussed was aggressive diet and exercise for weight loss. And 1 year prior to this, her serum albumin was 3.8 grams per deciliter. In terms of review of systems, aside from the generalized edema and weight gain, she also had fatigue and decreased appetite. Otherwise, everything else was negative: no fever, chills, sweats, no joint pains, no rashes. As we talked about, her history is significant for asthma, hypertension, gout, vitiligo, and she also has chronic hypercalcemia. She's only had a Bartholin cyst removal in 1990, no other surgeries, only allergic to shellfish. Medications, she's on losartan, hydrochlorothiazide, an albuterol inhaler, vitamin D. She took the colchicine and medrol dose pack for her gout, and she was also taking the ibuprofen for the last few weeks. Her social history is pretty unremarkable. She's a never smoker, never did recreational drugs, no alcohol use. Family history, no history of kidney disease or ESRD, just asthma, esophageal cancer, and hypertension. Her exam, when she presented, she was afebrile, hypertensive, but hemodynamically stable. She had about a 40-pound weight gain or 20-kilogram weight gain over the last 3 to 4 months. Her BMI was around 46. Otherwise, she had 3+ edema up to her thighs symmetrically. And she had some vitiligo of her right cheek extending to her chin, but heart and lung sounded normal. There were no other exam abnormalities. Lab data. So from one year ago, her adjusted calcium was 11.3, her serum albumin was 3.8, her PTH was 78, which is within the normal reference range, and cholesterol was 207 with an LDL of 143. 6 weeks ago, with a normal creatinine, her adjusted calcium was 12.6, serum albumin went down to 1.1, and total cholesterol went up to 573 with an LDL of 450. And on presentation to the ER, her creatinine was 3.98, her adjusted calcium was 11.4, serum albumin was 1.3, LFTs were all within normal limits, and her total cholesterol was 519, LDL was 413, HDL was 85, and triglycerides were 107. Her CBC was unremarkable. In terms of her serologic evaluation, her ANA, ANCA, anti-double-stranded DNA, antibody, HIV, Hepatitis B and C labs were all negative. C3 and C4 levels were within normal limits. Anti-PLA2R level lab was done and it was pending at the time. She had serum immunofixation done, which was positive for a monoclonal IgM lambda, and she had an elevated kappa lambda ratio at 2.45. Her urine immunofixation was negative. Urinalysis showed 4 plus protein, negative blood, and no cells. Urine protein creatinine ratio showed 8.2 grams per gram of protein, and the albumin creatinine ratio was 5.37 grams per gram. She had a renal ultrasound done, which showed normal sonographic appearance of the kidneys, no hydronephrosis, no renal lesions were detected, no renal vein thrombosis. She had lower extremity bilateral vascular duplex done, no evidence of DVTs, and a percutaneous renal biopsy was performed.
Thanks, Michael. Any questions for Dr. Coleman or Dr. Whittier, whose case it is?
How long had she been on the hydrochlorothiazide?
Years. Yeah, long time.
Years? Okay.
And her hypercalcemia dates back to at least 2016.
And was she on it then?
She was.
I remember reading something recently about how a lot of these patients that get hypercalcemic on thiazides actually have subclinical hyperparathyroidism, which kind of fits her PTH picture.
That was a paper years and years ago when I was a resident. That's what I brought it up. It may be talked about again now, but it was, I think, in the Green Journal, the whole issue of putting people on thiazides and all of a sudden they get hypercalcemic. You start looking for primary hyperparathyroidism.
Yeah. I didn't realize they had journals back when you were a resident, but I guess I can always learn.
Well, they came out with them between me and you.
It was chiseled in hieroglyphics back then.
I didn't catch it, but what is her total globulin?
Yes, I have that for you. Give me 1 second.
Well, while we're waiting, you probably don't recognize Dr. Whittier, but he's wearing glasses. This is his new attempt to look smarter.
No, these are Kirkland brand. They're very, very fancy. I got them at Costco the other day.
And while you're at it,
are they prescription or readers?
Readers.
Yeah.
Is the ionized calcium also elevated?
It is. It was, I think, if our reference range is up to 1.25, this was like 1.30.
Okay.
Like I said, it's been long-standing. I talked to her about a history of kidney stones. She had none. Her only complaint that I could possibly sort out is a little bit of the constipation related to hypocalcemia.
And had anybody ever measured her urine calcium at any time?
I checked it. I didn't put it in here, but I checked it. It was, but also she's on a thiazide, but it was 182.
Which is low for your lab?
Yeah, our reference range for females is up to 250, so it's not high. But again, I don't have a value off the thiazide.
Now she's also taking vitamin D.
Mm-hmm.
Actually, it just like the craziest question is, I may be on there, I didn't see, what's her parathyroid hormone levels?
78.
78. So it's
my bad. I'm sorry.
It's okay. It's definitely, I specifically went over this with Dr. Coleman, how we should say it's within the reference range, but obviously it's quite high for her level of hypercalcemia.
The upper normal used to be 65. I don't know what it is now, but
82 in this lab. So she's 70, but that's still too high for where her calcium is.
Yep.
Globulin level was 3.5.
Thanks.
Thank you.
Any history of sarcoidosis? Zainab is asking.
No, not per history. She does have a history of asthma, but she's not had hyaluronadenopathy.
Good question. All right, we're going to start with a poll. So I'm being very progressive here. I hope you appreciate how progressive I am in my terminology in my new poll. So I believe, I want everybody to vote on this. I believe this patient will have a podocytopathy with acute interstitial nephritis, a podocytopathy with acute tubular necrosis, a podocytopathy with segmental scars, membranous nephropathy, lupus nephritis, or 6, a monoclonal gammopathy of renal significance. In other words, you think a bone marrow should be done before a renal biopsy. Your voting is anonymous, so no one gets going to get called out. Give it a few more votes here. We have 35.
77% of the non-panel. Pretty good. A few more seconds here. Good. 80%.
All right. You want to, okay. So we've got about 20% says podocytopathy with acute interstitial nephritis.
Wow.
17% say podocytopathy with ATN. 8% say podocytopathy with segmental scars. 17% say membranous. So really kind of a similar voting on all those. But the number one vote is monoclonal gammopathy renal significance that feel actually a bone marrow should be done before a renal biopsy. So I want to hand this over to Dr. Corbett, who is our podocytopathy, our local podocytopathy expert. And since that was in the diagnosis here, I want you to discuss this case, but considering all these diagnoses, Steve.
Okay. So, I mean, the first thing that came to my mind, I have to admit, you put the first one up there, is that with her being on ibuprofen, does she have, the minimal change disease, hence the podocytopathy with acute interstitial nephritis, which would be a lymphocytic infiltrate. And she's got this extremely high cholesterol, which I know we talk about constantly about what the value, if any, of that is. But that's definitely high on the list in my mind. I don't recall now. I didn't write it down. But did she have any evidence of pyuria?
No, she had no cells, and her internist had checked her labs about 2 weeks before she was on ibuprofen, and her albumin was 1. So she didn't do. That was about 6 weeks ago, where albumin was 1, and her ibuprofen started about 3 weeks ago.
Fair enough. So I mean, I still think that's definitely high, at least on my list in the differential. Actually, 1 or 2 are kind of linked to me. It's it's also possible that she has minimal change disease with severe nephrotic syndrome, very low albumin. She's 59 years old. She's had a history of hypertension. These are the people who get NSAIDs and are more prone to have acute kidney injury, as Ron Falk and Charlie Jeanette showed years ago. So ATN's another possibility. You want to put back to the poll? Podocytopathy with segmental scars, I guess that's possible. It's not high on my list that this would be somebody with FSGS, if you will. And if it were, I'd be thinking of kind of a collapsing FSGS as fast as it seems to be going. But that's, at least at this point, that wasn't really high on my list. Membranous also wasn't.
Steve, I'm going to interrupt here. Steve, I'm going to interrupt. Why aren't you so excited about 3?
It seems that it's come on so suddenly to me. I mean, that's the only thing. I mean, collapsing FSGS can come on suddenly as well. I know we don't put this in the protocols anymore, but is she African American? Is she Hispanic or white?
She identifies as Black.
Okay, well, I guess that's possible. I just wasn't for some reason, this seemed to be so sudden. It just wasn't as high on my list as the first 2 being possibly related to ibuprofen.
Primary, what we used to call primary FSGS is not sudden onset, like minimal change?
It can be, but I just, like I said, that didn't, I mean, collapsing FSGS is a possibility. It's just in my list, it wasn't as high as ibuprofen associated minimal change in interstitial or ATN.
I'm not talking about collapsing FSGS. I'm talking about primary, podocytopathy with segmental scars. I mean,
it can be, but for me, it can be. I mean, there's no other way around it. It can definitely be acute. It can be acute, and she's developed acute renal failure with it, which can occur, with some of the, again, with some of these lesions. I mean, whether it be the tip lesion or the collapsing lesion.
Where is the acute renal failure?
I thought her creatinine was.
Her creatinine's 4.
Yeah, she definitely
okay.
has that. But
right,
you're
okay.
right, Dick, it was a little confusing on the timing.
got
The
it.
creatinine was 1 about 6 weeks ago.
Yeah, I mean, she started at 0.8, right?
Got it.
So yeah, over 4 weeks, she's up to
Got it.
4.
Thank you.
God, Dick, you're making me second guess myself now.
No, thank you. I understood now.
Membranous is possible too, but again, not high on my list. Lupus nephritis, is possible, but the serology.
Did he just get kicked off?
He just dropped off.
Okay.
Roger, while we're waiting for Steve to come back on, I really appreciate your efforts here to get away from the term minimal change disease.
That was all for you, Dick.
That's very, very modern of you.
You know what?
There's been now several calls on social media to drop the name minimal change disease entirely. So your attempt to create a new nomenclature is really appreciated.
Well, listen, there's two reasons. One, it makes a lot of sense, and two, we're all afraid of you if we call something by a name and not it's a pattern of injury. So either way, well, I think it's the right move. So
yeah,
I don't know. Steve's going to come back. So who thinks? Let me hand it over to Casey Gashty. Dr. Gashty.
You're back on again?
You're back on, Steve. Okay.
Yeah.
No, anyway, I think the other one was monoclonal gammopathy of renal significance. The only issue is, it's interesting, is she got IgM lambda, but it's interesting that the kappa lambda ratio is actually high. I would have thought if this was predominantly lambda-free light chains, it would be very low, but it was high in this case. And, you know, there's no question that this is not just light chain proteinuria, because she's got a lot of albumin in there as well. So the issue would be, is does she have something like amyloid or light chain deposition disease with CAS nephropathy, which can definitely coexist? I think it's a possibility. I have a funny feeling it's less likely. I still am going with whatever you want to call it, photocytopathy, minimal change disease, and an AIN or ATN related to the ibuprofen. I think it's interesting that the hypercalcemia, she has that as well. I don't know if she's got primary hyperparathyroidism, and the hypercalcemia may be adding insult to injury, causing acute kidney injury by way of afferent vasoconstriction and nephrogenic DI. What was her urine specific gravity was, it doesn't say, but I find that's kind of an interesting side. I don't think that that's the cause. That for sure is not the cause of her proteinuria, but it could contribute to her acute kidney injury. I mean, there's a lot of possibilities here.
And we added, the reason I put the poll like that is I agree with you. There's kind of a big overlap of interstitial nephritis and ATN and the pathophysiology, but I just want to make it kind of very, very specific kind of which you brought up, one being non-steroidal, one being just, hypovolemia and related ATN. But yeah, there is some overlap there, but that was the idea behind number 1 and number 2. And like you said, there's no, we didn't see any pyuria, but I don't know if that's 100% or not, right? Yeah, no cells, right? Thanks, Pravir. Dr. Gashty, do you think this patient should get a bone marrow first? Generally in adults, we often do a bone marrow first because we may find something for which we don't need to do a renal biopsy.
I think with a negative urine immunofixation, a kappa lambda ratio of 2.4 and somebody with a creatinine of 4, which is not high, and having lambda in the blood and having the kappa lambda ratio not be low, I'm not really that suspicious. I think she probably has an IgM MGUS. And even the urine protein, I mean, she's got 5.5 grams of albumin in there. So I think that the monoclonal finding is probably a red herring, and her disease is probably something else. I'm actually going to go with membranous as my number 1. I know there's vitiligo, and the lupus serologies are negative, and she's had vitiligo for years. I'm not really, convinced that this is lupus. So I'm going to go with membranous. And clearly, it sounds like the NSAIDs were started after the onset of nephrotic syndrome, which would make me think that the NSAID-induced minimal change disease would be also lower on the differential. So I'm going to go with membranous with ATN because of, her albumin being 1, her being predisposed. So, and yes, Dr. Whittier put in the chat the association of sarcoidosis and membranous, but I don't know if she has had the proper workup for sarcoid, in other words, an ACE level imaging with lymphadenopathy and things like that. So that's possible that she has sarcoidosis, but I think that the current explanation for nephrotic syndrome, I'm going to go with membranous and we're going to see some ATN as a result of severe nephrosis.
What about her asthma story? I mean, that's, you know, I always quote this, but you know, Dr. Kark would always call minimal change disease asthma of the kidney because of its association to asthma. Do you think that's, I mean, obviously asthma is more common in blacks and it's probably a red herring, but do you think that could mean anything or?
I mean, there are definitely hints of minimal change disease here. And I mean, there's, you know, the high cholesterol with a really low albumin with a sudden onset of nephrotic syndrome could certainly be minimal change disease. And whether it's related to NSAIDs or not, I mean, she could have that. And the history of asthma pads that argument a little bit that she could also have minimal change disease.
Casey,
Yeah.
Casey, can I ask you, do you have any clear idea as to how frequent ATN is in membranous nephropathy of acute onset? I must say, I've seen a lot of patients with membranous, and all the patients I've seen who had impaired renal function soon after the onset of their disease either had crescentic GN or interstitial nephritis. I can't recall ever seeing a patient with just ATN in membranous. Now, obviously, I've seen a lot with minimal change disease, particularly in older adults, but I can't recall ever seeing a case. How did you come up with that idea?
Well, I extrapolated that from the minimal change because my understanding of the pathophysiology of ATN in minimal change disease was the severe degree of nephrosis and hypoalbuminemia leading to tubular necrosis. And if the membranous is sudden in onset,
I'm not sure that's the full explanation. I mean, there are many hypotheses for acute kidney injury in minimal change disease. The predominant one is very diffuse foot process effacement, impairing the movement of water across the capillary wall. But I was just curious because I must say this is not the clinical features I generally associate with membranous nephropathy. But this case may be a real education.
Yeah, and I don't know the answer to obviously this case, but I also don't know how many people with severe, acute onset membranous will get ATN. But the reason I brought that up was really because of how hypoalbuminemic and nephrotic and how sudden all of this was.
Okay.
Yeah, I wish we really understood this AKI that's so common, well, not uncommon in minimal change disease. I don't know. I have to read more about this podocyte effacement causing the GFR, because I mean, it's not just a filtration issue. To me, it's, you see granular CAS, it really acts like an ischemic ATN, but
well, in the Falk Jeanette paper, it was older patients who had bad vascular disease who were more predisposed to the effects, the hemodynamic effects of the hemodynamic effects of a relative decrease in the intravascular volume. I mean, that was one of the ways they explained it. I know this whole issue of not everybody that's hypoalbuminemic with nephrotic syndrome is, has a low intravascular volume, but that was, their big explanation, at least as I recall it, had to do with how much more severe the vascular disease was in these patients.
We see it in kids too. I mean,
yes, of course, yeah,
and yeah, and and then I don't even go into nephrosarca, but that's it's a really interesting topic to me. I'm going to move on because Dr. Rubin wants to speak. Mario, please.
Thank you. Mainly for Casey. Casey, I'm glad you brought up the issue of possible MGUS. Along those lines, would a quantitative immunoglobulin assay help you pin it down a bit more? Obviously, it's a loaded question. And the other one is, would you consider AL amyloidosis here, assuming this is not an MGUS?
The quantitative immunoglobulins, I mean, if we have a really elevated IgM level, it could be helpful, but a normal level would probably not be very helpful. So we usually do check that, but I'm not really sure if in this particular case, if IgM is normal, that would necessarily rule it out.
Yeah, I bring it up alone again. I'm obsessed with Dr. Robert Kyle and his teaching. But from the get-go, one of the hallmarks of an MGUS is that you have an elevated, in this case, IgM, and the other immunoglobulin fractions are normal. On the other hand, if you have a myeloma, the other immunoglobulin fractions are low. So that is helpful. And the other thing is, I recently learned from Dr. Nelson Long that in an IgM elevation, the amount of IgM helps you in discriminating an MGUS versus a myeloma, as long as the IgM is under 1.5 grams, is consistent with an MGUS. So those are another things to keep in mind.
Mario, do you think this patient should have had a bone marrow first?
Yes, because it helps you assessing whether or not you're dealing with an MGUS or a full-blown myeloma. And I think nowadays, the molecular analysis of the bone marrow is very helpful.
Yeah, and I suppose they're
Well,
not mutually exclusive. I'm sorry, Dick.
I would take the position that a bone marrow is going to make a whit of difference whether you do a biopsy or not.
Well,
If this patient had
do
an
a
abnormal
screening-
kidney biopsy, it would be an indication to do a biopsy. So I probably would just go right ahead and do the biopsy.
Okay, respectfully, I disagree. I think that a bone marrow is helpful because you can do an amyloid staining on the marrow and it will help you. I mean, right there. You wouldn't need them to do a kidney biopsy, but again, it's fun to have agreements and disagreements.
Would you do a fat aspirate as well, Mario? Because at least from the Mayo Clinic, the feeling is you need to do both to increase the sensitivity of, picking up amyloidosis.
If I am at a center that knows how to do it, by all means. I think that part of the problem with false negative fat pad aspirates is the lack of experience of the operator.
Well, I don't know what the sensitivity of bone marrow staining for amyloid is, but I imagine it's pretty low.
I don't know, Dick, but I'll be able to find out.
It's not listed as the usual tissue to pursue for the diagnosis of
It's part of the
amyloidosis.
bone marrow analysis, an amyloid staining.
Well, what's the sensitivity?
I don't know. I will look it up and let you
Yeah,
know.
I thought it was something like 65%, to be honest. And that's why I thought the Mayo Clinic, their reviews, when I've looked at them, they say the combination of bone marrow and fat aspirate takes it up to like 95%. But again, as Mario points out, I mean, you've got to do it the right way. But at least the stuff that I've seen from, Maury Gertz at the Mayo Clinic is, you do both of them if you're going to do that.
I mean, also,
In this case, though, we've got AKI that's pretty significant, and I'm not sure we have enough time to. The bone marrow results for our institution take a while to get back. We can get the renal biopsy in one day, and
that's a
the
really
AKI
good.
here is really, really prescient.
Yeah, that's a really good point, Bill. I would just wonder too that this patient has a serum monoclonal gammopathy and may, independent of what we find on the bone marrow, on the renal biopsy, may warrant hematologic evaluation anyway. I would think that, any 60-year-old that has a monoclonal gammopathy should, but I don't know if that's true or not. Let's move on and spin the wheel, see who reads the biopsy. All right, put the wheel up. Oh, great wheel. Oh, wheel of wisdom. Oh,
Broke
there
a
we
sweat
go.
there.
Yeah. almost Dr. Baxi, but it's Dr. Saba, our second-year fellow. By the way, there's only a few more reads left for them, and then the first-year fellows get moved on the wheel. Hopefully, they don't quit the fellowship because of that.
Always put Melanie back on. Seems like she's joined. Go ahead, Saba.
All right, can you hear
All
me?
right. Yep, I'm gonna
Very
share,
well.
and then give me a second here. I'm gonna let you control the screen. Okay. All right, go ahead and click. Yep, you're controlling it.
All right, so here we have one core with the trichrome stain. I see 1, 2, 3, 4, 5, 6 gloms here. And then as far the tubules look back to back look okay, and then I see maybe 15-20% of like the fibrosis with the blue staining.
Yeah, if even that, yeah, very focal.
Focal.
Yeah, less than 5% really.
Oh.
Yeah, looks like a good preserved core.
All right, so we have our PAS stain here. There's one glomerulus in the middle. It looks maybe a little bit lobular. Otherwise, I don't really see much mesangial expansion, nor do I see a lot of hypercellularity, so it looks pretty good and intact. Maybe some loss of brush border a little bit in the tubules.
Okay. Yeah, a little bit of ATN and a normal glomerulus.
So this is our Jones stain, silver stain. The capillary loops look nice and open. I'm looking for any spikes or holes throughout, and I don't see any, so it looks pretty well intact as well.
Yep.
So David, right in the middle, the other marker for those that don't know of amyloidosis is the so-called eyelashes. I know you guys call it differently in rash. At rash, you call it comb or something like that.
Coxcomb, yeah.
There you go. I
I
mean,
call
in
it
the middle,
the Bart Simpson sign.
yeah, in the middle, it looks like maybe some of them may resemble that. I don't know. Maybe I'm overreading.
Yeah, I think you're overreading it. This is just a normal way of mesangium stains on the silver stain. Yeah,
Okay.
the Congo red was negative.
Okay, so we have H&E stain here. Again, I don't see any gloms here, just some tubules.
Yeah, the tubule right in the middle has, what do you think about in the loom? Yeah, tubule right, yeah. Some necrotic debris in the lumen, some
Okay.
ATN. Yeah, right there, slopping of epithelium.
Okay. Maybe
So
some.
there was ATN in the biopsy.
Okay. Another PAS stain, looking at the tubules, and then again, is this the same thing?
Yeah, and that too, yeah, right there, yeah, nice. You could see the loss of brush border and thinning of the epithelium going along with ATN and a couple of those tubules.
So we have H&E stain here. It looks like there's some sort of lymphocytic infiltrate right around here.
Yeah, this was in the medulla, nothing in the cortex, but you have the kind of a dense pocket of inflammatory infiltrate here. We'll see it at a higher power.
Yep, so same thing at a higher power. Looks like mostly a lot of lymphocytes here.
Yeah, and then yeah, you breezed over a plasma cell. There's occasional plasma cells. Keep going to the right and to the right. Yeah, and up. That one there's a plasma. See it as the purple cytoplasm.
Yep.
Right there. Yep.
You go back, just for teaching purposes, if this were to be a transplantation with a medullary infiltrate such as this one, what would you think about?
Sorry, can you say that again?
If this were a transplant, a kidney transplant recipient with a medullary infiltrate such as the one that is shown, what would you think about?
Like concern for like cellular rejection or
No, BK.
no,
BK virus characteristically affects the medulla, may be associated with this infiltrate. I mean, just a teaching point.
No, thank you. So immunofluorescence, we have IgG, which is positive and looks like it's almost like granular in appearance. Looks like it's yeah.
Yeah, right. Yeah, so that was my impression too. So I put an oil and went high powers. The next two slides are under oil, so we'll have some.
Okay.
Yeah. So you definitely see some granular staining on the capillaries.
Yeah.
Would you call, David, this a dusty appearance?
Yeah, well, we'll have to see. We'll have to see that and wait for the EM because I think you're implying a anti-nephrin, right? Yeah.
All right.
Again, same thing with the IgG, looks granular like we talked about.
Is there, I mean, it looks like there's almost like linear staining as well. Is that just me or?
No, I had to turn up the brightness to kind of get the granular deposits to photograph.
No, but even on the lower power, it looked like there was some sort of almost like that pseudo-linear that you see in diabetics. Or I mean, I don't think she has good pastures by any stretch, obviously, but anyway, it's just me.
The distribution of these powdery deposits on IF associated with podocytes more resembles the classical antinephrin response than it does membranous, but I agree EM is going to be critical in differentiating between subepithelial deposits and podocyte related deposits in this case, but it looks more like podocyte to me.
Okay, so here is our EM slide. So I'm looking at the podocytes here and they look fairly effaced.
Fairly are widespread.
A widespread.
Yeah.
Diffusely.
Yeah. And do you see any deposits?
No, that's what I was just looking for. I don't really see any deposits at all. So yeah, just the foot process effacement is what sticks out.
It's a nice picture. I mean, you've got the mesangium, you've got at least 3 loops coming off of it, maybe 4.
So again, a little bit higher power, same thing, seeing a lot of foot process effacement, and I don't see any deposits around here either. Yeah.
Yep. No, there were no subepithelial deposits.
Okay.
Again, same thing, pretty diffuse foot processes and no deposits.
Good.
Yeah.
Good reading, Saba.
Thank you.
Tell me what you call it.
Great question. I would call it definitely a podocytopathy.
Look at you. I'm so proud of you.
It has, but the positive immunofluorescence is a little bit confusing, and then there was some ATN and some AIN there as well. Is that
excellent?
Yeah.
I think that's a good description.
We don't routinely do an antinephrin stain on kidney biopsies, but I think if this were a case in the Brigham, this biopsy would have been stained for antinephrin to show that the IgG deposits co-localize with nephrin. And if they do, that is pathognomonic of an antinephrin-induced minimal change lesion.
Yeah, we don't have that stain here at Rush,
Yeah.
and neither does Mayo Clinic, our reference lab, so we don't have access to
Yeah.
that. You know.
It'd be
If you
nice, hopefully
contact,
someday.
If you contact Helmut Renke, they will run it for you, both in blood and they will do the staining
Yeah.
in the tissue as well. So I think it's worth a try.
Yeah, the medical center has to have a contract with whoever we're sending tissue to, so.
No,
yeah,
but
it
they
would
will
be
not.
nice.
They will not charge you, David, because they are desperate for more and more cases. So they will do it for free.
Yeah.
That's a good point. We have a diagnosis of a podocytopathy with ATN and some interstitial nephritis, and immunofluorescence that is not compatible with what we used to call minimal change disease, but appears like it's anti-nephrin related antibody podocytopathy. Let's go to our next poll. So how would you treat this patient? One, nothing. This will resolve spontaneously. I believe this is all non-steroidal related, which is one option. 2, steroids. 3, steroids and rituximab, or 4, CNI, no steroids.
Right. A good response already.
Yeah, you can end it. It's not going to change much. So the majority of people want steroids. A few people still are convinced that might be non-steroidal related, and and a handful of people steroids and rituximab. Casey, let me ask you, how would you treat this patient, realizing that her BMI is 46?
Steroids alone.
Well, you didn't really bid into that one.
No.
I mean, is there a consideration for something else? I mean,
Well, her creatinine is 4. She has ATN, so I'm not really a big fan of CNI at this moment. I usually save the rituximab for a relapse of a minimal change disease. So if this minimal change disease doesn't relapse, I wouldn't do it. And plus, rituximab will take a while to kick in, and steroids would be faster.
The option is steroids plus, steroids plus rituximab.
Yeah. Well, I mean, the steroids should take care of the interstitial nephritis. You don't need to do anything for the ATN and the minimal change disease. If it's really NSAID induced, it will probably go away by itself within a couple of weeks, but we don't know that. And so I think the patient needs steroids. The question is 2 versus 3. And I've never given rituximab as the first line, meaning first time I diagnose minimal change. It's usually in either steroid dependent or relapsing or recurrent cases of minimal change with nephrotic syndrome that I use Rituxan as a steroid sparing down the road. So my choice here would be 2.
Something that doesn't come up enough is the fact that 50% of people with minimal change will relapse. And from the standpoint of that, I don't think, and realizing that if she relapsed, she would require another round of steroids given her BMI. I don't think, or just in general, I don't know if that's such a crazy idea to give steroids with rituximab for the idea of having a much more prolonged remission or lack of relapse. But I don't know if that's ever been studied.
Well, I'd like to call a friend, David Mount, at the Brigham. He and his group is having a paper that is in the process of publication. They're having pretty good response in the cases of anti-nephrin with rituximab. So if this turns out to be anti-nephrin, I think I'll talk it over with him. It would be prudent, particularly with her sky-high BMI, to consider Ritux.
Ritux with steroids or Ritux alone?
They are using Ritux alone.
Alone for anti-nephron.
Mm-hmm.
How interesting. Okay. I could have put that as an option
It's
too.
a whole new disease, and I don't know the details of that paper, but in the conferences that they sponsor, which I have attended, that's what they underscore.
That's really interesting.
Good response to results.
Yeah. All right. I don't want to take any more time because Dr. Whittier's got some discussion for us. Bill?
Yeah, thanks. So yeah, I think when David called me with this, we discussed it and we thought it was very consistent with anti-nephrin. We didn't have access to it, but to the stain in the blood, like we talked about, but it's nice to know. I'd also contacted Arcana, and they also do not have access to it. So it's really limited to the Brigham. Let's see if I can forward this, or maybe, can I forward it?
Yeah,
there
you're
we go.
controlling.
So what I did is in the hospital, we started on prednisone 60 a day and Rituxan 1 gram times 1. I thought obviously her renal failure is due to ATN, but because she was so nephrotic with the renal failure, Rituxan alone, I wasn't really thinking of because I just wanted to get her into a quicker remission. I think, knowing how long it takes for Rituxan and other diseases to work, I think that it was important to do steroids, but I was also worried about her long-term steroid need. And so that's the other reason that I had given her Rituxan in the hospital. And her AKI, fortunately, ATN resolved in 1 week. Her nephrotic syndrome resolved in about 3 weeks. And she had gone from a creatinine of 4 down to normal, and her serum albumin had gone from 1 up to 3.8. And her urine PC went from around 8 grams to completely undetectable. So I wanted to bring up the nephrin situation and really go through this article. And actually,
Bill, I'm sorry to interrupt you,
go
but
ahead.
Dr. Astrid James is in the audience, so after you're finished, we should hear what she has to say.
Thank you. I was actually about to say that exact same thing. We invited Astrid here so that she can discuss this with us, and I'm going to go through her paper and she can correct me on the things that I say wrong about her paper. But we were very happy to have her here in the audience, so thanks for coming on, Astrid. I wanted to just go over every single protein in the podocyte. No, I'm just kidding. But what I wanted to go over was, where nephrin is, and it's in the cytoskeleton that joins the podocyte foot process together. And if we blew this up, you'd see that nephrin is here. And anti-nephrin antibodies are the target of this paper. And what they had done was initially shown that the anti-nephrin antibody was not in all nephrotic syndromes, but it was really chiefly in those with minimal change. That was the first step. The second step, or there are many steps, and I'm going to even skip over some just for the sake of time. But another step was they had about 18 patients, I think, out of 63 with had minimal change. And of the 18 patients, those are the ones that had anti-nephrin antibodies when the patients were nephrotic. On about, I think it was maybe these 10 or how many ever number are here, they also had blood on the patients. This is from the Neptune cohort, where the patients were in remission. And so what we're showing you here is what the nephrin antibodies were in the pink line or the red line when the patients were nephrotic, and in the blue line, what the anti-nephrin antibodies were when they were in remission. So you can really see here that not only was anti-nephrin only exclusively really in minimal change, except for I think one membranous patient had one, but they're very, very high when your disease is active, and they're also undetectable when you're in remission. And I really wanted to highlight what the immunofluorescence looked like, because in our patient, it had almost this linear appearance of the IgG, and it also had the speckled or the dusting pattern in the podocytes. And they noticed that these was not just albumin reabsorption droplets or something, because when they stained for albumin, the same dusting wasn't there, but it was really limited to IgG, and I believe it was IgG1. And you can see that here. And this really resembles our patient here. I kind of blew it up bigger for us to see, just took a segment of one of there from their paper, but you can see there is still that capillary wall, almost linear staining, but the real difference here, I think, and what they have noticed was the dusting. And you can argue, well, if it's this, then it's not minimal change. We have positive immunofluorescence. And there is a subset, though, of patients with minimal change who have had this. And so not only did they use the Neptune cohort to help define this, they also looked at their own cohort of patients at the Brigham over the years and started studying those patients too. And what they found was it did co-localize, just as Dick had said in the earlier in our discussion here, that it does co-localize to nephrin. That'd be the yellow here. The yellow is the overlap of the IgG with nephrin. And if they took a different protein, cytoskeleton protein, it did not co-localize with synaptopodin. So really pointing out here that nephrin's the issue. Nephrin antibodies are what the dusting is targeting, and that it's an antibody-mediated disease. This was then from their cohorts, and they also noticed that it was only in the patients who had the dusting was the nephrin positive. So the ones that were completely without the dusting did not have the nephrin positive. So it was about 1/3 of overall of their cases. I think it was maybe 18 out of 60 or so had the dusting and also had the positive antibodies. And how did those patients do, and what did they get treated with? Well, there was a hint. It didn't quite reach statistical significance, but that there was a hint for more relapses in the patients with anti-nephrin antibody positive and the dusting. And then they also went on to present a very specific case in this paper about a transplant patient who had gone on to get a transplant and had recurred in the transplant and then resolved once they gave plasmapheresis and rituximab, kind of pointing to this might even be the circulating factor that people have been looking for so long in primary FSGS that recurs in transplants. So our patient, I want to just go back to that before I ask Astrid to speak, to correct me on where I messed up on doing that in front of Astrid is a little bit humbling because I want to make sure that I said it all right. So correct me. But this woman, at about 4 weeks, though, she had presented to the emergency room with a steroid psychosis, which was significant. Psych saw her and they started to Abilify, but they really also wanted me to drastically cut down her steroids. Now, she hadn't been able to get her outpatient Rituxan second dose yet because of insurance issues. So I tried to ramp up her Rituxan dose as an outpatient because I had to cut down her prednisone to 20 milligrams because she really did have some significant psychosis. And her urine PC was undetectable, but now about 1 week after that, or about 2 weeks after I cut down the steroids, her urine PC actually went back up to 1.1 gram, and her albumin had gone from 3.8 to 3.6. So this is as of like labs from yesterday. So it's possible that she's sort of flaring again as I cut down her steroids. And hopefully this Rituxan will kick in because it does seem to be that it might be the treatment of choice for the nephrin antibody positive patients with minimal change disease. Astrid, do you
Hi everyone. Sorry, I came in a little late. Couple things. First of all, you did a great job. I don't have anything to add. You did a good job presenting our data. So it was nice to see my slides being represented. And then just a comment real quick. So that staining that you saw, it was very close to the GBM still in your patient. So it's a little different from the dusting that we had in this particular case, but in our paper, we also presented two different patterns of staining. One was the one that's really close to the GBM, very much following the slit diaphragms, whereas this one is probably representing clustered nephrin that's moved to a little bit more of an apical location in the podocyte, right? So it's probably a relatively early form or early stage of antinephrin injury. And if you actually look at that right loop there on the right side, you see these squiggly lines that I call some sort of the ramen noodle pattern. Those are actually the cell-cell contacts of the podocytes, right? Where they're actually touching each other, where the slit diaphragm would be located. So that tells you that in some of these areas, you probably still have an intact slit diaphragm, or it's just very early on in the removal of the nephrin. So that's one thing. And then the other, sorry, my husband's just calling me here. Gotta click him away for a second. And then what else do you want to know? So yes, at the Brigham, they've successfully treated rituximab alone, although I think it makes sense to maybe bridge over with some steroids first because the steroids kick in really quickly. Probably not because of the immunomodulatory role, but because there's probably a direct effect of the steroids on the podocyte. I could imagine something like increasing the nephron surface, trafficking and localization so that more of the antibody can be removed and more nephron is there to actually bind to reform the foot processes. Because remember, what you want to achieve is a state where your patient is able to reform the foot processes. So for that, they need intact nephron at the cell surface to reform the slit diaphragms. So I think that, in that context, plasmapheresis in patients that are really sick, that have severe AKI because of the severe nephrotic syndrome, where you're not sure that the steroids are going to really reach the podocytes very well. These are conditions where I could imagine plasmapheresis be extremely helpful. And I actually have some cases where where people were treated with plasmapheresis in a very acute phase because they were in basically oliguric renal failure because of the nephrotic syndrome, and came out of that really quickly, and you could really see the antibody levels dropping. And then after that, when the steroids were able to kick in and the rituximab was able to kick in, they could be removed. And I think they received 7 plex sessions in that particular case, but I don't know I guess you have to see how the patient is doing. But it makes sense. You want to remove the circulating antibody. You want to increase nephron surface expression. You want to maybe help the podocytes recover. That might be tacro, which acts on the actin cytoskeleton. And then that's your bridging regimen. And then rituximab will get rid of the cells that produce it. And this whole concept of just treating the ones that relapse, I'm not sure that makes all that much sense, because what you want to do is treat early, right? You want to kill the plasma cells that are the B cells that are responding to the rituximab, and you don't want to wait for memory cells and plasma cells to form that might escape the rituximab treatment. So this is just something that you should consider. But I think exactly, the pathophysiologic treatment approach is important. Think about the pathophysiology and then try to treat accordingly. And this is, I think, a prime example for that. Once we have the causal proof, which I believe is going to come soon, then you know what's happening.
So is there any association with NSAIDs whatsoever? Years ago, I think it was out of the Mayo Clinic, they talked about NSAIDs and membranous.
Yeah.
It's just a red herring here, or?
I don't know. I found it in NSAID-associated minimal change disease too. I'm not really sure what NSAIDs exactly do to induce this. I don't know. I can't tell you.
And then, go ahead, Roger.
Astrid, when PLA2R first came out, it was just the tip of the iceberg, although it's the majority of what we used to call idiopathic membranous. Do you think this is maybe the beginning of really understanding minimal change disease, if you will, or do you think it is just a subset and we'll still have these other ones?
Well, it's the majority, I think, of cases. So if we look at the cases that have the dusting and co-localized with anti-nephrin antibodies here, the Brigham minimal change disease, about 65% of cases. This is an underestimate in the Jason paper because these patients were mostly pre-treated already. These are complex patients that get enrolled in this study. So it's a little bit of a skewed cohort. But from what we've seen in kids with INS, we just had a talk at the ASN, 75% are positive. Minimal change disease, I would think probably between 60 and 70%. And then the rest, they have to be determined. There was just an abstract too at the ASN for CRB2 antibodies, which is funny enough because it's a nephrin co-localizing or associated protein, may lead to the same effect on nephrin in the end. But it's probably a smaller percentage of patients. So it is probably very similar to PLA2R, that this is 70-80%, and then the rest of it will be maybe other antibodies that lead to a similar phenotype. And in recurrent FSGS, we see it in about 50% of cases of recurrence in our cohorts that we've so far looked at, that we also showed one-off at the ASN as a poster. So it is it's a very interesting concept disease, and I think we're solving a good portion of them, and the rest will probably come soon, I would think.
Astrid, this is really exciting.
Roger?
Yeah.
I just wanted to thank Astrid and her colleagues for starting the revolution in our thinking about diffuse podocytopathies and hopefully eventually eliminating the terminology of minimal change disease and rather call it anti-nephrin nephropathy.
Yeah, it's my
But
quest. It's an uphill battle.
I want to make an analogy to anti-GBM disease, which I've had a lot of experience with. And you may know that in Sweden now there is a protocol treating minimal change disease with not only plasma exchange and rituximab, but imlifidase, which is a streptococcal enzyme which destroys IgG immediately. And it causes the anti-GBM antibody levels to fall to 0 within 24 hours. Much more effective than plasma exchange. I would not be at all surprised that once imlifidase becomes approved for the treatment of anti-GBM disease, which is probably likely, that it will also be applied to the treatment of these very severe acute renal failure forms of anti-nephrin diffuse podocytopathy, because the best way to get rid of anti-nephrin antibodies instantaneously is with imlifidase. A provocative statement, I admit, but there's a lot of similarity between anti-nephrin disease and anti-GBM disease, the difference being the antigen target.
The other similarity is pemphigus. You should read up on pemphigus. Very similar.
Yes.
Functional
Yeah.
protein, autoimmune disease, and they're much further ahead with their clinical trials and studies. So you should check it out.
Yeah.
I have to go, unfortunately. I have another meeting, but
Sorry,
I'm
Astrid,
glad to
one
be
more,
there. Yeah.
one last question, Astrid, if
Okay.
you can. There's a lot of talk about this being the factor, the permeability factor. Your thoughts?
I think it is. I mean, it is one of them. It's probably one of the major ones, and there might be others, but you know, this is definitely one of them. Yeah.
You have one, really quickly, Astrid. How did we miss this forever?
Because we're ignorant people and we want to see what we know, and we don't want to really forge ahead often, you know?
Yeah, but we do immunofluorescence.
Yeah. We saw it, and Helmut's been saying, Helmut Reinke has been stating for 25 years that this is an antibody-mediated disease at every single Columbia course he gave. And he was laughed at. That's, you know, just something to think about.
I personally would never laugh at Helmut Reinke, so.
Well,
I know better.
There are others that would and did.
Yeah.
And so you know, it was very hard to get this paper published, and, you know, you don't know how hard it was. And it's really going against a paradigm that is extremely established. And so it's tough.
Well, thanks for joining us. It's revolutionary.
Sure.
We're all excited as you can imagine. Have a great day.
Thanks,
Thank
Astrid.
you so much. Sorry for leaving. Bye.
Thank you.
Anybody else have any thoughts about how we missed this forever on immunofluorescence? Dick, what do you think?
Partly, Roger, is that immunofluorescence doesn't always contain albumin. And a lot of these little dustings were attributed to protein reabsorptive droplets in the podocyte erroneously. Whereas, in fact, they are antibody deposits on fragments of a redistributed nephrin protein. So the key was doing confocal microscopy in the biopsy samples. And of course, Reinke should be given credit for that along with Astrid.
Dr. Whittier, what protocol of rituximab you use for how long?
The only one I use for everything is 1 gram on day 1 and then 1 gram on day 14. I know there are different protocols. The real question is whether I would give another one at 6 months or not. And honestly, if she is relapsing right now after I've given her 1 gram and still relapsing after the second dose, my next, plasmapheresis is my next option.
Did you check to see?
It's hard specifically to get her up on higher dose steroids because of the previous because of her previous reaction.
Do you check the CD19 levels? Because I know in RUMC-RBC's paper, which looked at steroid dependent and frequently relapsing, they give one dose and that usually did it and then they would check the CD19, and unless it was less than 5 cells, they'd give a second dose.
Yeah, well, I have not checked that, Steve. It's a good point, but I think if she is relapsing, despite getting that gram, I kind of feel like I know she's not depleted.
I mean, who knows if this story really plays out the way it seems, that maybe we'll have a serum marker that the same equivalent of PLA2R, and we'll treat that level, and we'll treat it preemptively like we do PLA2R. I mean,
Amazing.
maybe this is a little bit premature, but it sure is an exciting thought. And boy, have we waited forever. I hope this is it, because we've waited forever for this story to get a little clearer.
But Roger, you have it now. Astrid can give you a titer on the anti-nephrin in the blood, and you can follow that as a marker of pheresis if you institute that, or rituximab if you plan to continue it. Now, as a word of caution, the infliximab story, remember, was advanced by the group at Cedars for the treatment of antibody-mediated rejection. And although a lot of people welcome it with big enthusiasm, it didn't pan out. So I'm interested in learning more about the anti-GBM role of this drug before we jump into using it in other ones. But it's a novel approach to these diseases by all means.
Well, something can be done now. That is to encourage pathologists to stain biopsies for antinephrin antigen and with confocal microscopy, which should be available in many pathology laboratories until we have the serum measurement commercialized.
I think that
it's sort of like what happened with PLA2R antigen. We had the pathologist embraced PLA2R antigen staining fairly quickly. Well, they should do the same thing, I think, in minimal change disease with antinephrin staining.
I think we forgot to ask Astrid, but I think I recall her saying that a company in Germany is able these days to give you results of an anti-nephrin, and perhaps they'll branch out to the US and we'll get it here.
Right.
Well, exciting days ahead, and you think about all the advances we've had in glomerular pathology in the last decade. It's really remarkable. It makes this such an exciting field. Thanks everybody. Thanks, Bill. What a great case. Thanks for thinking to invite Astrid. She's a superstar, and what a treat to have her here. We'll keep an eye on your email for our next conference. Until then, everybody stay safe.